I will be giving a talk on chemotherapy-free regimens and the treatment of acute lymphoblastic leukemia in adults at SOHO this year. The kind of origin of chemotherapy-free treatment for acute lymphoblastic leukemia started really with the treatment of Philadelphia chromosome-positive disease with tyrosine and kinase inhibitors that specifically blocked the constitutive tyrosine kinase activation through the BCR-ABL1 oncogene, fusion oncogene. The initial use of drugs like Ponatinib in combination with chemotherapy, and then second and third generation tyrosine kinase inhibitors that overcame the resistance, some of the resistance mechanisms to Ponatinib, ultimately led to the use of Dasatinib and other tyrosine kinase inhibitors in combination with steroids alone for the induction of remission in acute lymphoblastic leukemia. And those regimens have shown complete remission rates in the 90 to 100% rate with induction, with basically no induction mortality. Complete molecular response rates aren't high, though, in the 20 to 40% range with that approach alone. And most patients will relapse after drugs like Dasatinib and Prednisone if they don't get additional chemotherapy or transplant. More recently, some very powerful targeted therapies have come along that are starting to be used without the addition of conventional chemotherapy in pH-positive disease. And the recent results of the GIMEMA Italian D-ALBA study have been very impressive with induction with Dasatinib and corticosteroids with a very high complete remission rate, and then consolidation with Blinatumomab, which is a bifunctional T-cell engaging antibody that targets the patient's T cells to attack and kill any remaining leukemia cells that haven't responded to the Dasatinib and steroids. And they show a very excellent overall survival and disease-free survival. However, with longer follow-up from the original publication, there are a number of relapses, and many of these relapses show the T315I mutation in the BCR-ABL1 oncogene, which makes the leukemia resistant to Dasatinib. This resistance can be overcome by using another tyrosine kinase inhibitor called Ponatinib, which also targets the T315I mutation. And recent studies from MD Anderson have shown with shorter follow-up than the D-ALBA study that Ponatinib and Blinatumomab together are extremely effective in terms of remission rates and basically 100% survival and disease-free survival out to 1 year with follow-up ongoing. So that's a very exciting approach that with just 2 drugs, non-conventional chemotherapy drugs, we're able to achieve, at least initially with short follow-up, basically 100% efficacy of the treatment. We have to wait to see in those studies what the central nervous system relapse rate may be and whether other mechanisms of resistance are present there. Following on this, we haven't had such powerful targeted therapies as tyrosine kinase inhibitors in pH-negative ALL. And so right now we are developing, studies are ongoing, and some studies have completed looking at chemotherapy-free regimens for pH-negative ALL. The first of these was the use of Blinatumomab alone in older patients who were transplant ineligible in the SWOG 1318 study that was led by is led by Anjali Advani at Cleveland Clinic. And with Blinatumomab alone in older patients, the complete remission rate was 66%. However, there were ongoing relapses in most of those patients, or a lot of those patients who received Blinatumomab, and again, follow-up is ongoing. Turns out Blinatumomab's efficacy is probably best in low burden disease. And so to try to take advantage of that, an ongoing study that I'm leading through the Alliance for Clinical Trials in Oncology is combining a targeted drug called Inotuzumab Ozogamicin, which is an antibody drug conjugate using an antibody to CD22 that's conjugated to a very powerful chemotherapy called calicheamycin. And when this antibody drug conjugate binds to the surface of leukemia cells, it's internalized, the chemotherapy is released, and you get very focused killing of cells that express CD22. So following on this success in pH positive of reducing disease burden prior to the administration of Blinatumomab, this study aims to achieve high complete remission rate and minimal residual disease negativity rate with Inotuzumab Ozogamicin. And that approach has been also reported in a European study where their complete remission rate was 100% and a very high minimal residual disease negativity rate. Then following that with Blinatumomab, very similar to the DALBA study or the MD Anderson study in pH positive disease, to try to potentially affect cure in a large number of patients with sparing them the toxicity and possible treatment-related mortality of conventional chemotherapy. So as far as challenges moving forward to these approaches, one, we don't have long follow-up of these approaches. Central nervous system prophylaxis is pretty standard with intrathecal chemotherapy, but whether that's sufficient to prevent CNS relapse in a fair number of patients, we don't know yet. We also don't know what the long-term resistance patterns and whether late relapse will be a problem with these approaches.